All right, everyone. I think we will go ahead and get started as people are coming in. While they're doing that, if you've been on before, and most of you have, you'll remember we start off each session with introductions in the chat. So if you want to go ahead and introduce yourself with your name and where you're joining from and your organization, that'll be great. We'll keep an eye on the chat throughout. And just a reminder, if you've got questions during the presentation today, during our discussion, you're welcome to unmute and ask it yourself, or you can throw it in the chat. I'll be monitoring it. But I'm really excited about today's presentation, today's speaker. So we've got Rachel Byers here with us from the Utah State University Institute for Disability Research Policy and Practice. I was excited about this for a few reasons. We can get into that in a minute, but I'll quickly introduce Rachel. Rachel has a Master of Public Health degree and is a certified health education specialist. And she became passionate about human services provision and research throughout her undergraduate degree while working with children and youth with dual diagnoses. She worked in Pocatello, Idaho in management for a residential habilitation service provider, where her interest in disability service provision and research peaked. She's passionate about health equity and quality services provision, and she currently works on the mental health team in the research and training division at the Institute for Disability Research Policy and Practice at Utah State University, and is an adjunct instructor for Idaho State University. So I was really excited that she agreed to join us today. For a couple of reasons, partially because in my a previous life, I was an employee at Utah State University. So while I have my degree from SUU and I work at SUU now, a little part of my heart will always be an Aggie. That was my first job when I graduated from college. So with my undergrad. So I was really excited that she was willing to join us. And I actually also was excited because we've talked about how health equity impacts all of us. And obviously it's impacted all of us in different ways, but I have a sister with who's she's pretty low functioning on the autism spectrum. She's got some pretty severe disabilities, and I know that's affected our family a lot, especially growing up in rural Utah where there weren't a lot of services available. It just was a real challenge for us. And so it's something that I've been passionate about, and something that I am so grateful for people like Rachel who dedicate their professional lives to finding solutions. So with that, again, I'll be watching the chat, but if you have any questions, feel free to pipe up and ask, and then we'll go ahead and give the rest of the time to Rachel.
Thanks, Austin. Like he said, I am from the Institute for Disability Research Policy and Practice at Utah State University. That's where I spend most of my time, but I am an adjunct instructor for Idaho State University. I teach a promoting wellness course for their undergraduate students. It's one of those things I like to do as a health education specialist, helping people who are moving into adulthood learn how to establish healthy behaviors and kind of learn about their health choices. So this first slide here, I'd like to include this prompt hierarchy. It's a little tie and connection to how I began working with people with disabilities when I didn't really know what I wanted to do when I finished my undergraduate degree and was kind of not sure where I should even go. And I stumbled upon a job listing working with people with disabilities. And I thought, oh, that sounds really interesting. I've had good friends growing up with disabilities, and it's always something that I've been passionate about. And I ended up working in this position and managing supported living supports for adults with disabilities. And a lot of that had to do with making behavior plans and person-centered planning, things like that. So that's what that tie is to, that prompt hierarchy. And then you have my two dogs next to that. Outside of this, I'm a pretty vanilla person who lives in Logan, Utah currently. It's freezing. I was just talking to Austin before you all joined. It's very cold and there's a lot of inversions. So this is when I wonder why I live in Logan, but when the spring comes back, I'll remember why I live here. And I'm really excited to be here today. So a little bit of background as to why I'm here. We have a subcontract with the Utah Department of Health and Human Services, specifically the Office of Health Equity, where we are working on health disparities for people from rural areas, specifically people from diverse backgrounds and individuals with disabilities. So through that funding, we have done lots of trainings for community-based organizations, different local health departments. It's possible that if you're from one of those organizations, you may have seen my face before. Kind of just depends on who you work for and where you're from. But that's what's making it possible that I can do this today. We have some funding from the Utah Department of Health and Human Services. And as a little plug for the Institute, this is our 50th year of operation. We've gone through a few things like a name change over the 50 years, but we also have a lot of people who are established here at the Institute who have been working on disability services for the community for decades. So we do what we can, and we've been doing this for 50 years. A little bit about what we'll go over today. First, we'll talk about some perceptions and beliefs related to disability, and that can be personal perceptions, organizational perceptions from where you work. We'll then look at some of the official definitions that shape how we provide services and some of our perceptions of people with disabilities. Then we'll talk about disability over time, how some of those perceptions and beliefs have changed, how some of those definitions have changed, and how our treatment of people with disabilities has changed here in the United States. We'll look at disability statistics and experiences of people with disabilities in Utah specifically. We'll have kind of a rural element there. And then we'll look at health disparities that are experienced by people with disabilities. And there's a lot to unpack there. So I think that'll be important. We'll look briefly at disability services in Utah, what that looks like. Austin, I'd be curious to hear a little bit more about your experience with your sister. In rural areas of Utah, it's definitely hard to access disability services. And then finally, we'll wrap up with some strategies on how to work towards health equity for people with disabilities. So I'm hoping that by the end of this presentation, you'll be able to identify 3 health disparities experienced by people with disabilities, describe some of the elements of historical treatment and perspectives that we have on people with disabilities, and finally, identify 3 ways to support health equity work for people with disabilities. So to get us started, you can unmute and share if you'd like. You can share in the chat, but I'd like to know what comes to mind when you hear the word disability. And that could be something that you picture, words that come to mind, experiences, anything along those lines. I'd like to hear anything that just came to your mind when I said disability.
I would say struggling with how, I don't know, with just how we shape the world. You know, we shape it a lot of the times not thinking of people with disabilities or special needs. You know, that we oftentimes this world is constructed in a way where we don't keep them in mind or as much in mind as we should.
Yeah, thank you, Carlos. Anybody else? What comes to your mind when you hear the word disability? Got a comment in the chat from Ariel, ramps, wheelchairs, accessibility. Awesome, thank you. Limited capability. Oh, I like this, Suzanne. Everyone has abilities and disabilities. It's just that some people's disabilities are less obvious than others. Anybody else? Adaptation. Thank you.
I also think of like people's movement or like how they're able to go through life, like if they you know, are able to drive, or if there's extra things, you know, I guess I don't want to say extra things, but like things that they need in addition to be able to, you know, move around the world and function. I think of like, you know, specific classes that they take, or, you know, to be able to do occupational like therapy, things like that.
Thank you. So the reason I start out with that is because we oftentimes have perceptions and beliefs related to disability that are shaped by our experiences. And that's reality for us. And there's nothing inherently wrong with the perceptions or beliefs that we have. But it's good to review those, to think about how you think about disability, how you view disability. So that's something that I'd just like you to keep in mind as we continue through this. Take this information and compare it to what you previously thought. Official definitions do guide how we provide services and how we really shape the world of disability that is around us. Carlos, you mentioned we don't really create the world with disability in mind, and we are trying to change that. And one way that we do that is try and have definitions that are functional and useful. So currently, the CDC's definition of disability in general is any condition of the body or mind, which is an impairment, that makes it more difficult for the person with the condition to do certain activities, activity limitation, and interact with the world around them, which would be participation restrictions. So it's really interesting. I wish I had some comparisons, but we only have so much time today, how the definition of disability has changed slightly over time. It's important to think about how we even define disability. Sometimes that looks different in different cultures, and we'll talk about that in just a minute here. But this is one of the official definitions that we use to determine eligibility for financial services, for supported living services. So there's a lot that hinges on this official definition and other definitions like it. When we're looking at disability, and especially disability services and making accommodations, there are a couple different types or categories of disabilities that can affect what people qualify for, what adaptations they might need. And here at the Institute for Disability Research Policy and Practice, two types or categories of disabilities are very important in the work that we do. One is intellectual and one is developmental. And you'll see in just a minute here that there's a lot of overlap, but generally the official definition, one here being from the American Association on Intellectual and Developmental Disability for intellectual disabilities, is that it is a condition characterized by significant limitations in both intellectual functioning and adaptive behavior that originates before the age of 22. So you'll notice an important part of that definition is that there is an age bracket. And then for developmental disabilities from the CDC, they are a group of conditions due to an impairment in physical, learning, language, or behavior areas. These conditions begin during the developmental period, may impact day-to-day functioning, and usually last through a person's lifetime. There's a lot, like I said, a lot of overlap in between intellectual and developmental disabilities. And the more time that passes, the more we learn, the more we have to kind of adjust the way that we define disability and diagnose disability even. For one example, you might be familiar with the term Asperger's. That was once considered a separate diagnosis from autism spectrum disorder, and it is no longer included as a separate diagnosis. It's just autism spectrum disorder. Cerebral palsy is one that you may be familiar with, fetal alcohol syndrome, attention deficit hyperactivity disorder or ADHD, Down syndrome, and spina bifida. These are all examples of intellectual and developmental disabilities. And it's not uncommon for someone with a disability to have signs and symptoms of both intellectual and developmental disabilities. So when you're working with someone with a disability, it's important to consider that you're probably going to need to keep a very open mind and very open perspective when you're thinking about what adaptations that person might need and how to go about providing the best services. There is so much that we could learn about disability history. This is basically, I took a 3-hour presentation about disability history and took 2 minutes of very condensed information. If you would be interested in learning more, I'm happy to share more information with you guys at a later time. But essentially, disability, how we view it, how it's defined, and the role that people with disabilities play in society varies greatly between cultures, across continents, geographically, and has changed significantly over time, particularly here in the United States. We have changed language that we use surrounding disability. For a long time, it was popular to use identity first language. People were labeled as, for example, a schizophrenic individual. And then we shifted to using person first language. So instead we would say a person with schizophrenia, or a person with fetal alcohol syndrome, or a person with Down syndrome, instead of a Down syndrome person. And right now, there's actually a lot of conversation around personal preference as far as language goes. Some people actually want that identity first language as a way of owning their disability and taking charge, essentially. Some people still do prefer that person first language. And moving forward in this presentation, I'll be using person first language because I'm not working with an individual person and I wouldn't know their preference. And out of respect, I will be using person first language. But that's just one example of how things have changed over time, even in just the past 2 decades. And there has been significant changes in advocacy and empowerment and the way that society interacts with individuals with disabilities and provides supports and accommodations. We'll have an example here on this next slide. Unfortunately, the United States does not have a great track record when it comes to working with people with disabilities. This picture is a little bit grainy because it's an older picture. I can't remember exactly the date for this. I'm going to put a link in the chat. I'll put 2 here. One is a link to the Institute for Disability Research Policy and Practice website. And the other is a link to the source for this picture. The story behind this picture is that people with disabilities were part of the eugenics movement. Generally, anybody who didn't fit the quote neurotypical mold or quote normal functioning level was considered not enough. And when you were looking at the eugenics movements of the early 1900s, people were discouraged from continuing bloodlines or genetics for people with disabilities. So in case you can't read some of this picture, and this is a real thing in the Midwest from several decades ago, it says some people are born to be a burden on the rest. Learn about heredity so you can help to correct these conditions. And they have these flashing lights to present a visual display. And the top one, this light flashes every 15 seconds. Every 15 seconds, $100 of your money goes for the care of persons with bad heredity, such as the insane, feeble-minded, criminals, and other defectives. And you'll notice here, they're using these terms to criminalize people with disabilities, people who are different from the quote norm. And then below here, they're saying we need less of these, which is people who will never grow up mentally beyond that stage of a normal 8-year-old boy or girl. And then they directly relate that to being criminal by saying every 50 seconds, a person is committed to jail in the United States, and very few, quote, normal persons ever go to jail. So they're creating these associations that people with intellectual or developmental disabilities are inherently criminal, essentially. And they're promoting the idea that only people who meet this bar that they've created should be allowed to continue their genetic line. Even as someone who had a background in working with people with disabilities, I had no idea that this was part of the United States history. And up until honestly, you know, so I started working here, I had to learn so much. There was so much I didn't know about how the United States treated people with disabilities. So this is just one powerful example that I think really conveys some understanding about how poorly people in the United States treated other people who had disabilities earlier on. And there are lots of examples. Something that's important to think about is when I say we, I mean the United States. There was, for a long time, for decades, there was a practice of ostracizing people with disabilities, separating them, institutionalizing them. And within those institutions, they were treated very poorly, very, very poorly. There are some documentaries that explore that I'd be happy to share if any of you are interested. But the idea to take away here is that historically, here in the United States, people with disabilities have been treated very poorly. And this is something that we have had to work on really hard. And even in the recent decades have had to do a lot of advocacy work, and including people with disabilities in that work, because part of this conversation is they never had a say in how they were being treated. They were treated as less than, and now we need to actively include them in the work that we're doing. And we'll talk about strategies to do that later on today. I am curious, after seeing this picture and listening to me drone on for a minute about the history of how we treat people with disabilities in the United States, have any of you, is this new to any of you? Does this strike you as surprising? What are your initial reactions here? And again, you can put that in the chat or just unmute.
For me, it fits into the historical context. I mean, yes, this behavior was atrocious in the United States, and historically, World War II, Germany carried it to the next extreme. Anyone who is disabled or emotional or mental handicap was basically taken and killed.
Mm-hmm.
Because of their policy for a quote-unquote pure Aryan race. And they didn't want any DNA or genes going down to the next generation. And just like your slide here,
Mm-hmm.
perpetuating a species of quote-unquote less than.
Thanks, Robert. And we've got a comment in the chat that it's not surprising with how there was little known about mental illness. That's a great comment. There's also a lot of overlap between disability and mental health. There are mental health challenges that can be so significant that they're considered a disability. It was frequently the case that individuals in institutions, they would have disabilities and mental health challenges. There would be individuals who didn't have intellectual or developmental disabilities or physical disabilities, but who were suffering from a mental health challenge and didn't have the resources they needed, and they were all just kind of lumped together. Anybody else? Another comment in the chat, not surprising, still have difficult to get help today for these individuals. That is so true. We'll look at some numbers here that will help paint that picture and help us understand how difficult it can be to get services. All right, well, that was hopefully the most heavy part of this presentation. Just kind of sobering to think about the history there and how far we've had to come to get to where we are today. But to paint the picture a little bit about what disability looks like in Utah and why this is important for health equity work, for healthcare work in general, approximately $4.8 billion per year is spent toward disability healthcare costs here in Utah. And that is 29% of the state's healthcare spending. I do think there's something to be said for the definition of disability healthcare costs, what falls under that umbrella. But this is a staggeringly high number. It's a massive percentage of the state's healthcare spending. So why is this so important? Well, we spend a lot of money on disability healthcare, and there are a lot of people who stand to benefit from these services. And Carlos, I see a comment in the chat here. At Holy Cross Ministries, we have a program called NEFF. We actually partner with Utah State University. We bring experts to come and give presentations. Awesome. I'd love to connect with you after this, Carlo, about your program and to see who you're working with.
Yeah, of course.
So this gives us an idea of why we should be paying attention to healthcare services for people with disabilities and equity in those services and outcomes. 497,000 adults in Utah have a disability. So we're really close to 500,000. That is a very big portion of our population. You'll see that this is equal to about 23%, close to 1 in 4 adults in Utah. So there are a lot of people in Utah who identify as having a disability. And that definition is huge. We looked at the CDC's official definition earlier. There are a lot of things that fall under that category. But that being said, there's a massive proportion of people, adults here in Utah, who report having a disability. So we spend a lot of money on disability healthcare spending. There are a lot of people in Utah who identify as having a disability. And in case you were curious, and this is something I can also potentially drop in the chat or provide later, I can send my slides also. Austin, I believe you have them, but I can send you the most recently updated copy to distribute if you'd like. I went and looked at disability data that we have in Utah to see how that prevalence shows up in rural and frontier counties. Something that you'll notice here, Summit is the lowest prevalence in all Utah counties, and then Paiute is the highest prevalence of all counties throughout Utah. So just something to consider looking at this list. I don't know, depending on where you're from, you may find your county on this list and just be able to see what that prevalence looks like. Something to keep in mind, in these rural and frontier counties, there's a massive range of disability prevalence. Like I pointed out, Summit is the lowest county in Utah, and Paiute is the highest. Something that we think is really, really important here at the Institute for Disability Research Policy and Practice is listening to people's lived experiences and learning about what it's like to live the life of a rural Utahn with disabilities. And throughout the years, we have gathered some of these stories, and occasionally we'll have blog posts or fact sheets where we highlight lived experience. And one example I'm putting in the chat here, it's the one that I have linked on the slides. This article, I would encourage you to save this link and read it later on. It explores 5 different stories of rural Utahns with disabilities in Utah and about how they navigate living life with a disability in rural Utah, including accessing services, accessing things like wheelchairs, assistive technology, and things like that. It's very eye-opening to actually learn these stories from the people who live this life. So again, I'd encourage you to look at that. We also have ongoing projects here that explore the lived experience of people with disabilities. This is one of the projects with the Utah Department of Health and Human Services, the Office of Health Equity. As part of this project, we completed a landscape analysis, and that included interviews and focus groups, talking to people with disabilities, talking to mental health providers, learning about challenges that are faced and barriers that are in place for people with disabilities when accessing employment, mental health services, and health disparities in general. We also have another project called Mental Health and Intellectual Developmental Disabilities, where we look at specifically mental health services provision for people with disabilities. If you work specifically with mental health or you're passionate about mental health for people with disabilities and equitable access, I'd be happy to grab your email and include you on our list for this project. It's a 5-year project, and what we're doing is looking to create some resources for people who provide services for individuals with disabilities to improve training and education so that individuals with disabilities really can get the services that they need when it comes to mental health. So we looked at the number of people with disabilities in Utah, which was close to 500,000 as far as adults go. And I do think it's interesting to look at the breakdown of what type of disability they reported. And you'll see here that the largest category is cognition. And we have the second being mobility, followed by hearing, independent living, vision, and self-care. So, and it's possible that a lot of these people could identify as having multiple different types of disabilities, but it is a good perspective provider to look at the types that are broken down in data when you're thinking about what services to provide and what accommodations you need to make. This is where I'm very passionate about working with people with disabilities in general, but particularly with my background in public health and health education. I am very, very passionate about health disparities and working towards equitable health outcomes and healthcare access and improved quality of services. So this slide is very, very important to me. Adults with disabilities in Utah. So this slide is specific to Utah, what you're looking at here. The blue bar is adults without disabilities, and the orange bar is adults with disabilities. You'll see that they're far more likely to experience depression, have obesity, smoke, have diabetes, and have heart disease. The depression disparity is something that I'm particularly interested in. As I mentioned previously, we have mental health related projects here at the Institute. And what I'm curious, when you're looking at these disparities here on this graph, are you surprised? Is this something you've seen in your work? Is this something that maybe you're addressing in your work? Is your organization aware of it? What are you thinking when you are looking at this? And again, you can put this in the chat, or you can feel free to unmute and share that way.
I think for me, sadly, it makes total sense, because those are things that we already struggle to begin with everybody, you know. If you add a disability to the mix, it's just, yeah, I can see how that is. It makes sense to me.
Yeah, thank you, Carlos. Anybody else have some initial thoughts?
Makes a lot more sense. If I can, all those comes along with it. So we tend to categorize anything that is dealing with the mental illness, and then which, in my opinion, should not be. Then all that leads to all those outcome that is not positive, obesity and diabetes and all that. So yeah, that makes more sense. But I seen the other side of it, where I have friends who have disability no caused by car accidents and all that, but they pull up their way. They're professor now. They were captain on the Olympic team for the basketball team for the USA, won a couple gold medal. So I seen the positive side of that. So, but yeah, those number and that graph, it really shows or demonstrate that anything else that we come with it will definitely affect them to be able to just work like everybody else. I think, in my opinion, we try to normalize something, but it's not. Normal is not normal. I don't know if that makes sense, but we're always trying to put someone to a normal stage, which is not existent in nowadays. So normal is different to everybody else. And that's my thought, but.
Thank you. And we've got a comment in the chat. Ariel, I was surprised by the data. I did not realize how much greater that health disparities are for individuals with disabilities. Yes, we find that's the case for a lot of people. They just aren't aware or don't realize how big these disparities are. It's typical that people aren't aware unless they are connected to someone with a disability and then would have some knowledge about this, which is part of the reason why I'm here, to help spread this information. Thanks, Ariel. Okay, we're going to delve into a few of these disparities since we really don't have enough time to go through all of them, but a few that are pertinent right now. I'm going to drop this link in the chat that I have right here on this slide. And this is COVID-19 materials for people with disabilities. Fortunately, now that it's been several years since the onset of the COVID-19 pandemic, we have developed a lot of materials for people with disabilities. Early on in the pandemic, we didn't have those resources in place. And people with disabilities, I can give you a real life example. At the time, at the very, very onset of the pandemic, I was moving from Idaho back to Utah, and I was seeing this play out in real time at the organization that I had worked for previously. We became short-staffed very quickly. We didn't have enough people to provide the services for people with disabilities. We had individuals in our care who were very afraid, didn't understand what was happening. They were concerned that their benefits would be affected. And there was a lot going on that was uncertain and really prominently affected their lives. We also had individuals in our care who had severe health concerns. And so then we were even further concerned about their health within the context of COVID-19. So COVID-19 was really a challenging time for a lot of people with disabilities, especially people living in group settings or receiving supported living services from paid staff. Like I said, fortunately now we've developed a lot of materials to help people with disabilities in the context of COVID-19, and we've made a lot of progress in a lot of ways. But that was one example recently when there was a definite disparity in outcomes as well. People who became sick with COVID-19, people with disabilities were more likely to have a severe case, and they also struggled to access vaccines depending on how they were provided care. It could be difficult to access transportation to get a vaccine if they didn't have anyone to take them. Having information about where and when to get a vaccine, there was a lot that went into that. And ongoing, this has been the case historically and still is the case. Unfortunately, people with disabilities are much more likely to be victims of domestic violence. They have an overall higher lifetime prevalence than people without disabilities. They experience violent crime at approximately 2 times the rate of people without disabilities. They are 3 times as likely to be sexually assaulted. And unfortunately, police are less likely to respond to reports of violence against people with disabilities. And there's a lot that goes into that. There's a lot to be discussed there, but this is how it looks right now. These are the current statistics. And for me, this hit hard, having seen the service provider side of things for disability, and just seeing how services are provided and how easy it could be for someone to be victimized. This for me was important. Here at the Institute for Disability Research Policy and Practice, which is the longest name ever, and sometimes I get winded just saying the name, we have a couple people who are very passionate about domestic violence, and it is absolutely on our radar that this is something that people with disabilities experience at a higher rate, something that's very important to us, and we're hoping to be able to influence positively going forward. Since we're talking about health equity and kind of equitable health care and outcomes, why do you think it's important that we address domestic violence and these situations for people with disabilities related to healthcare? Why might this influence their need for healthcare? I see a comment in the chat. They already feel like they do not have a voice. They may feel like they aren't able to advocate for themselves. Yes, thank you. Can I ask? Yes. Why is it important that we consider these statistics about domestic violence and sexual assault when we're thinking about health equity and healthcare for people with disabilities? They may feel like a burden already. That's a comment in the chat. Yes, thank you. The more we know, the better we can craft solutions that work. Absolutely. Thank you, Robert. Domestic violence is already a public health issue, and then you add disability to it, and that adds on to their health needs. Correct. Thank you, Ariel.
Can you hear me?
Yes.
I think also being a victim of these types of things can lead to other health disparities and health concerns, both physically and mentally, if they're not properly addressed. And I think just, knowing that they're impacted more often and not often believed or taken seriously by law enforcement or others, it just makes it so much more important for providers to understand this and to be trauma informed and to help them feel like they are believed for their experiences and have an ally to help them get the services they need.
Absolutely. Thank you, Brittany. Teresa made a comment in the chat. Knowing they're more susceptible creates a disparity. I do believe that plays a role. And Megan, sexual assault and domestic violence is already a problem in our community. Being able to see statistics helps us better understand what needs to be done to prevent it in the future, as well as what resources we need to implement for these problems. Absolutely. Thank you, everyone.
I think it is good to know those things because it does help us to create a more efficient healthcare system. I mean, isn't it the goal to come into a preventive healthcare? So if we get to that, then it would require less medical care.
Mm-hmm.
If we catch all those things before and create a system that is more efficient for disability. That's what I think about.
Yes, absolutely. Thank you. Ariel, I really appreciate your comment in the chat here. One of the requirements for a client to come into our shelter is the ability to care for themselves if they cannot and they are a victim of domestic violence. I can only imagine how much harder it would be to get help. That is absolutely the case. Sometimes people with disabilities may have difficulty getting help when they're in a domestic violence situation because the person perpetuating the crime may be considered their caregiver. There's a lot that goes into this, and unfortunately we need to move on, but if anyone is interested in continuing this discussion or learning more, I'm going to drop my email in the chat here. I am always happy to answer questions and provide resources. And thank you for everyone that provided some input. So briefly, disability services today. Earlier, we talked about how the United States treated people with disabilities through the early 1900s and approaching the 20th century, 21st century. Currently, Utah functions, and this is a very brief overview, there's a lot you can go into here. Essentially, Utah operates on a Medicaid waiver-based system for disability services. And we have what's called the Division of Services for People with Disabilities, who does a lot of really, really great work providing services and connecting people with resources. Unfortunately, the need is much greater than what we can provide services for currently. This number you see here on the slide, which is 4,427, is the number of people who are currently on the wait list for services from the Division of Services for People with Disabilities. And that number is probably even greater because this is from the most recent annual report. It's probably increased since then. So we have thousands of people who are on a waiting list hoping to get services. And this may be a little small on your screen, but it does have a breakdown of the requested types of services. And two of the most requested services are in-home support and respite, and personal assistance and supported living. So we have people who are on this wait list who would really like some support in living their daily life and functioning. And unfortunately, we don't have the capacity to provide that to everyone who needs it. And the reason I bring this up is that if you have someone with a disability who is in need of services, but is unable to get those services, how might this affect health equity for them and general healthcare efforts for them? If they aren't receiving basic disability services, how might that impact their health? And particularly, what might that look like in rural or frontier areas? And this is where, Austin, I'd be curious to hear maybe a little bit more about your experience with your sister.
Yeah, no, I'd be glad to pipe in here. So it was always really interesting to get sort of, I didn't really obviously grasp what was happening as far as care went until we got a little bit older. But we had her in the home. So to give a little background, she received a diagnosis, an autistic diagnosis as like a 3-year-old. So quite young, and she's mostly nonverbal, and she has some other diagnoses as well. She's got a bipolar diagnosis and an anxiety diagnosis, and so those 3 things working in tandem really caused some interesting situations in our household. But we kept her in the home, and she attended public school until she was, I think, 15. And then eventually we were able to get her placed in American Fork at the disability center there. She was there for about 6 months, and then we were able to work with Chrysalis here so I'm from Cedar City, grew up in Cedar City. We were able to work with her there. And then my parents recently moved to the Wasatch Front, and obviously there are more services there, so they were able to move her as well. That honestly, I think, was the biggest challenge for my parents at first when they first received the diagnosis, was just finding services. So at the time, even St. George isn't what it is today. It was quite a bit smaller, and the resources weren't there. And so you had the Wasatch Front, where even, you know, we talked about how much this has all changed in 20 years. So in the 20 years since her diagnosis, even the Wasatch Front didn't have high quality resources. But when you got outside of that, there just was nothing. I mean, there really was not a lot to lean on. And so really it was just finding support. It was finding parents in similar situations. It was finding providers who had even just a little bit of experience treating people with disabilities and working with people. It was eventually we were able to connect with some providers through DSPD, and they really helped and were really influential. In school, it was really hard. The special ed program in Iron County specifically at the time was not very strong. And so it was really difficult to find people that could, you know, be a support. And I know it was a real burden on my parents. I can't even imagine how that looked, not only caring for her, but caring for the rest of our family. And so it was really difficult. Those things are improving. I am so grateful for the advances that are being made. There are resources available, and people are gaining more exposure to people with disabilities and special needs. And so it is improving, but just really the exposure wasn't there. And so you didn't know what you didn't know.
Mhm.
And luckily now we're at a point where the exposure is getting there, and providers are starting to gain that experience. So we are seeing improvements, at least I've noticed them in my lived experience. I can't speak for everyone, but I'm grateful for the advances to be made. That's not to say there's not more to be done, but yeah, that's a little bit of my lived experience with it.
Thanks, Austin. We are running a little bit short on time, but for this slide, I think it's important to think about how, as Austin mentioned, it's harder to access services in rural areas. They're fewer and farther in between. And thinking about healthcare needs and wellness needs, if certain basic needs aren't met, that can influence other needs. So it's important that we advocate for disability services for people with disabilities to support their overall well-being and health. Now, the hopefully fun part of this, we get to talk about how we can actively work towards health equity for people with disabilities. So I'm hoping that when you leave this presentation today, you walk away with something concrete that you know you could implement or change that would help improve health equity for people with disabilities here in Utah. A few examples to help kind of get the thought train started. Here at the Institute, we try and stick to a nothing about us without us approach, which means including people with disabilities in every step of what we do. And one way that we do this is creating things like advisory boards. When we have a project, we will take a group of individuals who are interested in that project, who have lived experience in the area, and they will kind of guide and direct what we're doing on that project. We will listen to individuals with disabilities. We will actively involve them in planning projects, get their feedback on ways that we will approach certain things. Another thing that I do personally, and we also do here at the Institute, is challenging stigma and harmful beliefs. And if we had more time, I would delve more into this. This could be a whole presentation on its own. But essentially, now that you are aware of the healthcare disparities that people with disabilities face, and you know some of that history about how they were treated in the United States, you have a perspective and you're able to provide essential influence when you are working on health equity efforts. You now have the knowledge that people with disabilities have experienced certain disparities at a higher rate, and they may need more of a certain type of service. And I'm hoping that it'll take that information, and if somebody has says something that dismisses people with disabilities or indicates that they may not be very important when you're working on health equity, I'm hoping that you'll be able to challenge that with what you've learned today. And then working towards accessibility. Accessibility is a word that's very inclusive of a lot of different things. We have web accessibility specifically, which refers to online accessibility. In today's day and age, a lot of people get their information about health online, whether that's social media, going to websites, and people with disabilities often face extra barriers when accessing those online resources. Fortunately, there are some resources out there that help us figure out whether you are at a local health department or a community-based organization. Help us so that we can create websites and fact sheets and infographics that can be accessed by everybody who would like to access that. I am dropping a link here in the chat. Specifically here at the Institute, we have a resource called WebAIM, and they focus on web accessibility. So if your organization is interested, or you personally are interested in learning more about how people with disabilities can have more access to our online materials, that is an excellent resource for you. Liz, I do see your question in the chat about what is a resource for helping people apply for a Medicaid waiver. What I can do is put together a little list here. I'll send it in an email to Austin this afternoon because we are running real short on time, and with an answer to that question as well as some other things I've seen here in the chat, and I'll make sure I get that to you, Liz. I was hoping that we would have a little bit more time to talk about how you can use these approaches in your work, but we are just about time to wrap up. So I am hoping that you'll take these examples and think about how you can apply them in your work setting or even personally, especially when talking about challenging stigma and harmful beliefs about people with disabilities. And this is a little bit more about that web accessibility. If you aren't familiar with the Americans with Disabilities Act, Title II requests equal access to programs, services, and activities. So it's incredibly important that we are working towards this. And a few examples specifically of web accessibility that you can think about for your online resources are making sure to include audio descriptions and captions, making sure web publications are assistive technology friendly. So an example of that would be someone who may be visually impaired can use a screen reader to access your online materials. All right, we are just 2 minutes shy of 1 o'clock. I do have my references here for anybody who's interested. Again, I'll make sure I get these most updated slides to Austin so he can send them out. I really appreciate everyone who contributed today in the chat and who unmuted to participate. I hope that there was something today that was helpful. And again, if you have any questions at all related to health equity and disability, please feel free to send me an email. I'm also seeing Carlos put his email here in the chat to send any cases for Medicaid if you have questions related to that. Happy that I could share. Please reach out if you have any questions. Thanks for having me, Austin.
Oh, of course, this was wonderful. And as you can tell by the things coming in, I can tell it was something that was impactful and something that we can all take with us in our professional practice going forward. So huge thanks to Rachel for joining us today. And I will send out information and slides as soon as we can. And then otherwise, we hope to see you in a couple of weeks, and we'll get you going on some more presentations. We're officially halfway through the series, so we can that's a benchmark for sure. All right, thanks everyone for joining us. We'll see you all next time, and then feel free to reach out if there's anything else we can do for you.